He's a fellow of the Royal College
Now,
of Physicians
moving on
in London and the
to
American.
the third item, and this is broken down into 5 different areas and therefore represents the bulk of my talk. We're going to deal with the psychiatric issues in epilepsy. Now, depression. Depression is a significant problem in people with epilepsy. The problem of depression is seen in people when they're first identified with epilepsy, but it's also seen as part of the process. And as you can imagine, faced with any medical diagnosis that will change your life, when a diagnosis of epilepsy is made, think what it does to you. If you're an adult, all of a sudden you can't drive safely until you're cleared. There are going to be the issues of the fear of having a seizure at work. What will my work environment think about that? Am I going to lose my job? What is the stigma associated with epilepsy as he or she already knows it, right? From having it before. How is that going to affect how they function? I have to be on medications. I never took medications before. These drugs have effects themselves, some of which include depression. These are significant ongoing issues, and it's a problem. People have examined the issue of depression over the years, and there is an interictal dysphoric disorder that Bloomer described in the past, with what were felt to be fairly typical and distinctive symptomatology being paroxysmal irritability and a euphoric mood. Now, I will say that most of the time, my impression is that patients labor under the difficulty of the diagnosis in the context of societal stigma, and that itself creates the majority of their problems. But there are real relationships between the epilepsy and depression. And one sees that in the context of the pre-ictal state of rising tension and dysphoria that many patients will tell you about. They kind of know when they're going to have that they're going to have a seizure. They can't tell you why, but they get increasingly anxious. And the seizure itself acts like an ECT, and they get rid of that and they feel better after the seizure. But they kind of know it's coming, and it's a horrible state. And so you as a physician, how do you deal with that? Well, you check on whether they're taking the drugs. You tell them to get enough sleep. You may even give them an anxiolytic, which of course, if it's a benzodiazepine, may also have anti-seizure properties. Sometimes these things actually don't work, and it requires the seizure for them to get over that state of rising tension. Sometimes, in fact, the anxiety is ictal, meaning it is actually the manifestation of the seizure. If a simple partial seizure, and remember definitionally, a simple partial seizure is one in which you don't lose awareness. The seizure is coming from one part of the brain. It can produce anxiety if it affects the limbic system. In other words, if the limbic structures are affected, like the mesial temporal structures and so on, the only manifestation is this ictal anxiety. And if the patient is having non-convulsive status epilepticus, meaning the seizures, the electrical discharges are ongoing, then it's a persistent state of anxiety. And that is the manifestation of the seizure itself, something that can be very difficult to recognize, especially if this is the only manifestation of seizure in that patient. And again, that is something for you to think about. Post-ictally, we talked about the fact that they can get elation or a sense of comfort and so on. That can happen as an ECT effect. Like, by that I mean electroconvulsive therapy. Remember the old I shouldn't say the old. The electroconvulsive therapy that used to be very often used and is used a little less. But post-ictal depression, often with psychotic ideation, is also a real phenomenon, and perhaps is seen in the majority of people rather than the minority. What are the risk factors for depression and epilepsy? It's not really sure if it really comes from one part of the brain. We talked about the ictal type anxiety. yes, certainly that's associated with ictal depression. But we're speaking about interictal, meaning a chronic state of depression. Perhaps there is some evidence that temporal lobe epilepsy may be associated with it. What's clear, though, is right hemispheric epilepsy seems to have a higher risk of depression. And obviously, we talked about stigma. There's the issue of epilepsy surgery. And this is something I may revisit during my talk on more than one occasion. Epilepsy surgery is a definitive form of management for patients who have intractable epilepsy, meaning drugs don't work. And if you can identify one part of the brain where the seizures are consistently coming from, you can take it out, provided it's safe to do that. Now, in the early days of epilepsy surgery, despite good clinical outcomes, there was a high rate of depression. And as I will allude to later on in my talk on suicide, the suicide risk in early epilepsy surgery series was 88 times higher than patients not so treated. And the reason for that, and again, I will talk about this again later, is you intervene in a patient who has chronic epilepsy. These patients are dependent. They are in a highly protective and supportive environment. They don't have to go out to work. They don't have to look after their needs. And then you cure them. And then everybody says to them, well, you know, I looked after you for 15 years. You're now well. Off you go, right? They can't cope. They've never been allowed to learn how to function independently. And they're thrown out into this cruel world. And they're asked to do it all on their own. That's the reason why depression was so common. That's one of the reasons why for epilepsy surgery, psychiatric counseling and pre-counseling, pre-surgical counseling, and ongoing counseling is critical in the long-term success of the patient. Remember, success of the patient is not simply rendering them seizure-free, but actually seeing them integrated into society effectively. Now, I don't have the time nor the expertise to speak about treatment of depression, but in principle, most antidepressants can be used. The risk of triggering seizures with antidepressants is largely overestimated. In the only actual placebo-controlled study on amitriptyline, the risk was not greater, despite the perception that amitriptyline lowers seizure threshold. That doesn't mean to say that giving a patient 150 milligrams of amitriptyline per day won't lead to them having a seizure. But you know, it's an important point that within the therapeutic range, it was not a particular problem. Mild depression, St. John's wort, may be useful, but SSRIs are particularly useful. One caution: fluoxetine can increase serum levels of the anti-epileptic drugs, and you need to remember that if a patient's side effects from their drugs seem to be getting worse, it may be because of a pharmacological drug interaction. And even ECT can be used for the management of these patients. Now, on to the second aspect of psychiatric issues in epilepsy is perhaps the most worrying and concerning. And I shouldn't say concerning. All aspects of psychiatric dysfunction epilepsy are concerning, but perhaps the most florid is the psychotic aspects of epilepsy. This has a long history. It was recognized in the mid-19th century in Europe, and then people came up with the antagonism hypothesis that schizophrenia and epilepsy were opposing phenomena, and that if a patient had psychotic features, it was less likely that they had epilepsy. We know that not to be really true, and work that began in the 50s has shown that there are definitely psychiatric aspects to epilepsy. Over the years, a lot of epidemiological, not a lot, some epidemiological work has been done. And when you look at the prevalence of psychiatric disease in various case series, you recognize that it is all related to the bias of the populations that you're looking at. Psychiatric disease is obviously most prevalent in psychiatric case theories, uh, less so in neurological inpatients, then in epilepsy outpatients, and least of all in general practice, which would give you a best sense of what the general population prevalence of a disease is. And there have been only 4 population-based studies of psychosis and epilepsy. And as you can see, the range is comparatively much less, but still significant. So if you average it out at about 5 or 6%, that's still significant. Now, what are the risk factors for psychosis? Think of your patient who has epilepsy. You're thinking to yourself, 5 or 6% of my patients with epilepsy, no matter what, could have psychosis. What are the patients that I need to particularly be thinking about? There's a slight female excess. Patients in whom epilepsy starts in adolescence seems to be another factor. Left temporal lobe seizure onset seems to be particularly associated with it. And complex partial seizure types, especially when there's a long history of it with multiple seizure types and intractability, as demonstrated by poor response to drugs, seems to be another one. There's a very interesting, there have been several interesting studies that have demonstrated a fairly consistent observation that it takes about 14 or 15 years for patients from the onset of their epilepsy to develop psychosis. But it is a quite consistent thing across many studies. And people have wondered if this represents a sort of kindling effect in the limbic structures, which are in fact very much adjacent or very much a part of the area where the seizures themselves are coming from. As I said, most of them seem to come from the temporal lobe. Left-handedness and underlying pathology of low-grade tumors, being gangliogliomas and hamartomas, seems to be the constellation of clinical features that defines the patient at risk. So you should remember these. Patient with epilepsy, female, seizures started in adolescence, temporal lobe sounding features on evaluation. Now 14, 15 years from the onset, meaning they're now about in their mid-30s. Left-handedness. And if you have had imaging that demonstrated something that isn't yet operated on, that's the patient.